Hello CP6 and welcome to the supplemental lecture of the knee. Before we get started, just as a reminder, this supplemental lecture is not meant to replace your readings, the knowledge you've already gathered from your CP2 and anatomy courses, as well as concepts you've probably covered in CONA, and if you were in differential diagnosis, you've also covered a lot of these concepts as well. The knee is a very popular joint. Generally, when we think of the knee, we think of the tibiofemoral joint. We're also going to cover the patellofemoral and the tibiofibular joints as well today. So stay tuned for those, but we are going to start with the tibiofemoral joint as that's kind of the knee proper. Here we're just going to look at our bony anatomy. Again, if we think of our tibiofemoral joint here, that's kind of mainly what we think about in the knee. This is called a modified hinge joint. Generally, when we think about knee mechanics, we think of flexion extension. Those are readily available. We think of those. But don't forget there are some glide motions as we move from flexion into extension and extension to flexion, as well as some rotational components, especially if we talk about the screw hole mechanism. So as we extend the tibiofemoral joint, we get that little bit of external rotation, and the tibia kind of sits nicely into the femur via the meniscus. And again, we'll cover that a little bit later, but again, just to kind of keep in mind some of those mechanics moving forward. So again, if we think about our tibiofemoral joint, we're obviously thinking about these two. A little bit later today, we will cover the proximal tib-fib as well as the patellofemoral joints here. If we look at the knee on the lateral side and the medial side, obviously the medial side does not have the fibula versus the lateral side has the fibula. Again, it's important, especially in any extremity, to kind of keep those landmarks in mind. It's very easy as you move from the left to the right to be on the lateral side and then keep those same hand placements, and then all of a sudden what was your lateral hand now becomes your medial hand. So again, very easy to get lost in these articulations and structures. The knee is a little bit easier because it's a little bit larger anatomy, so it's easier to comprehend versus the foot and ankle, which we covered last week. There's a ton of bones, and going from one landmark to the next can be pretty daunting as you're learning, but most of these structures are a little bit easier to palpate. As we look at our knee, we have a ton of structures that support the knee. So if you remember from our last lecture, we talked about the concept of joint by joint approach, which would be the foot is stable, the ankle is mobile, the knee then would be a stable joint, and then hip would be mobile, so on and so forth. So if we think about the knee, it really should be stable. So it makes sense that it has so many articulations that stabilize the knee. One important aspect to realize with the knee is while it is stable, it still has a very large range of motion. So if we look at the knee in general, extension being 0 degrees and flexion being somewhere between 130 and 140 degrees, again, depending on your patient, depending on the resource you look at. The important thing to note with that is that it's a soft tissue approximation that stops flexion. It's not necessarily a bony stop that limits that knee flexion. So again, there's a lot of range of motion in the knee for it being a stable joint. But again, that stability comes not only from the ligamentous structures, which we were just about to cover, but also if you think about all the dense muscular structures around the knee that support it as well. So as we're looking at this picture here, again, you have to orient yourself in the knee. Luckily, we have the fibula on the lateral side, so it's very easy to realize when we're on lateral versus medial. If we're looking at the knee, we have 4 very important ligaments. So we'll start with the collateral ligaments, which are on the medial and lateral sides of the knee. So we have the MCL, obviously on the medial side, the LCL on the lateral side. If we look at them from a medial and lateral view, you can see the structure of them is very different. It's hard to articulate necessarily in this picture, but you can see, again, this just kind of emphasizes how much dense tissue is around the knee, whether it's ligaments, muscles, or fascia, kind of holding everything in play. But the medial structures in the knee tend to be, not the medial structures, the MCL or the medial collateral ligament tends to be a little bit more broad and band-like, whereas the LCL is a little bit more cord-like. So again, the structure of those is a little bit different. We'll talk about each one of those functions a little bit later. This is a kind of a good representation of that LCL. It's kind of the band-like, and then obviously we have those structures from kind of a top-down view here. And we'll come back to that in just a second. But so let's orient ourselves. So we have the MCL, medial collateral ligament. LCL, lateral collateral ligament. We have the anterior cruciate ligament. It attaches on the anterior tibia. It moves posteriorly. Then we have the PCL, which is the opposite, moves on the posterior aspect of the tibia and moves anteriorly. Again, these are cruciate ligaments. Very important, all of these ligaments, for structural stability of the knee. If we break them down kind of side by side, if we look at our MCL first, it's very easy to injure this structure. And one thing to keep in mind with the MCL is you can see in this picture here, it has an attachment into the meniscus, which I guess we'll talk about now. So you have not only your 4 ligaments of the knee, 2 cruciate, 2 collateral, we also have our menisci. If I come from a top-down view, it's very easy to see how these meniscus are shaped differently. On the medial side, we have obviously our medial meniscus, which is more of a C shape. Then we have our lateral meniscus, which is a little bit rounder. It's not exactly a full circle, but it does, those 2 points articulate together very well. The main function of this menisci is to deepen the articulation between the femur and the tibia to kind of create some sort of depth to that joint. Secondarily, the menisci are good for shock absorption. So as you step, they take a little bit of that load, so it's not just all going into your long bones and onto the cartilaginous structures on the femur and tibia. So that's something to keep in mind too. Again, not only do they deepen that articulation, but also provide a little bit of shock absorption. Now, as we look at the shape of the meniscus, it's important to note, again, the C versus the oval shape, but the meniscus is a little bit thicker on the outsides and thinner on the insides. One other aspect of the meniscus is that the medial meniscus tends to be a little bit more stable, while the lateral meniscus tends to move a little bit more. And I bring that up because we see a lot more injuries to the medial meniscus versus a lateral meniscus, so maybe that's because the lateral meniscus is able to move around a little bit freer, doesn't take quite as much stress and load, but also don't forget about that attachment to the MCL on the medial meniscus. So we'll talk about that a little bit later when we get to conditions. Before I get down there, let's talk about the screw home mechanism. So as the knee goes from a flexed to an extended position, the tibia is going to externally rotate about the femur, and that will allow, if I picture this as my tibial surface and this is my femoral surface, it'll allow the femur to sit a little bit deeper in that articulation and create stability. I bring that up because that's also the closed packed position of the knee, that fully extended position. And again, we've talked about conditions in just a minute here. Don't forget that the knee, while we primarily think of it as flexion extension, there is a rotational aspect, and that can lead to a lot of injuries further down the road. From this lateral view here, this cross-sectional, I just want to kind of keep note as well. So we obviously talked about the tibia and the femur. Here's the patella here, how those surfaces articulate, how these surfaces articulate with your menisci standing there. But don't forget about these fat pads, and don't forget about the bursa. In the knee, especially the prepatellar bursa, is very superficial, very easy to injure this structure. So again, if you haven't covered this concept, or maybe you forgot, bursa kind of act like, one, they're little airbags, so it protects structures, and 2, it helps for things to glide a little bit better in tight areas, so kind of around tendons, ligaments, things that can be easily injured. But this prepatellar bursa here, very common in collision sports, or really anything in general, even kneeling for a long period of time. That prepatellar bursa can become inflamed, and it blows up to a pretty big size. So again, it can look a little bit daunting when you first see one, but again, remember to rule it out in your differential diagnoses. They tend to clear up pretty easily on their own. So I guess since I started, I'll go about all the other injuries we're going to cover today. So I think the first thing to realize about the knee is, generally speaking, we're looking at traumatic injuries. That does not mean there are not chronic issues with the knee. There absolutely are. But when you kind of think of the knee in general, the first things that come to mind tend to be your ACL tears, MCL tears, meniscus tears, things like that. And they kind of jump out at you, and they're really easy to remember. We'll talk about chronic conditions in the knee a little bit later too. And also we'll talk about how the knee, kind of more so than the foot and ankle even, can be referral pains from anywhere else in the lower extremity. The first structure we're going to talk about is the MCL, or medial collateral ligament. As we're talking about the MCL, it's important to note that, again, this tends to be a traumatic response. There's not necessarily a lot of chronic injuries to the MCL. You can wear them out over time. But again, normally it's, if you're looking at a non-contact injury, some sort of plant and twist mechanism that stresses on the medial side. So some sort of valgus force. Bringing that in, obviously a blow to the lateral knee can also emphasize that lateral or that valgus force, which can lead to MCL tears. The important thing to note with MCL tears is, again, we have this attachment onto the medial meniscus. Very easy when you injure one of these structures, the other structure can also be injured or at least irritated, even if it's not torn or damaged. The nice thing about MCL tears now, they tend not to be operated on as much as they used to in the past. It used to be, 15, 20 years ago, MCL tear, they'd go in, they'd suture it, it would take a longer time to heal, and the outcomes weren't great. Now, a lot of times they look to conservative care first. And so you're looking at a short period of rest, and then a longer period of rehabilitation, and then a return to activity. So again, very good for our profession to keep in mind those MCL injuries, because again, they're not operated on as much anymore. So again, that's something we can attack with our rehabilitative strategies. I'll also bring up the medial meniscus now, just because they're right next to each other. Same thing, if you looked, 15, 20 years ago at knee injuries, if there was a medial meniscus injury, sometimes they would take out the entire medial meniscus. And that led to a lot of complications later in life, where you're getting that bone-on-bone rubbing, because, again, that shock absorption of the knee can happen at the meniscus as well. So, again, a lot of times you'll see medial meniscus as a conservative management first. And then if they have recurrent issues, or they get something like a bucket handle tear, where when they're going from flexion to extension, that knee actually gets stuck and they can't fully flex or extend their knee. That's something where they'll look at operative care. But again, a lot of times it's conservative management, which is really good for chiropractic care. If we go to the lateral side and we go to the LCL, it's injured far less than the MCL. Again, you can have kind of a plant and twist. The mechanism is a little bit different, because normally you're extended and then you have kind of an adduction moment. So again, it's not super likely you'll see this one non-contact. If it is a contact injury, obviously it's a blow to the medial side causing a varus force. It doesn't mean they can't happen, but again, something to kind of keep in mind that it's not as common as your MCL or medial meniscus tears. Lateral meniscus, again, tends not to be injured quite as much as the medial meniscus. It doesn't mean it won't be by any means, just a little bit less common. But again, repetitive twisting over time, any plant and twist motion can injure the meniscus structure, whether it's medial or lateral, but again, tends to be more commonly the medial meniscus. Now, if we look at our cruciate ligaments, again, ACL is probably the one you think about most when you think about a knee injury. Again, generally traumatic by nature. There's non-contact and contact forces for ACL injuries. Again, normally some sort of plant and twist. A lot of times you think of the anterior cruciate ligament when it tears. As the femur internally rotates upon the tibia, and the foot and obviously the tibia are planted to the ground, it can shear the anterior cruciate ligament. So something to keep in mind, that obviously you can have non-contact injuries, and then you can have contact injuries as well. Normally this is a forced hyperextension injury of the knee. Even a blow to the lateral aspect of the knee, just like our MCL or medial meniscus, can also tear the ACL. And that brings us to the unhappy or terrible triad, whichever one you prefer, which would be an ACL tear, an MCL tear, and a medial meniscus tear. That is a long injury, because obviously we have multiple structures injured. But if we look at something like the MCL and conservative management, again, you're looking for anywhere from kind of 4 to 8 weeks, depending on how in-depth the tear is. An ACL tear, if we're looking at a grade 3 tear, we're looking at kind of at least 9 months. Really, I'd recommend somewhere closer to a year for return to play. It takes a long time for that structure to heal. So again, major injury to the knee, Generally, it's traumatic by nature. You're not really seeing chronic ACL tears necessarily. They can fray over time. But again, something to keep in mind with ACL tears. And really, most of the structures we've talked about so far tend to be traumatic injuries. As we continue on with some of the pertinent knee injuries, the next thing we have to cover is the PCL tear. Again, this is less common than ACL or MCL. Generally, when you think about it in the textbook, they say it's a dashboard injury. So the patient has a flexed knee. They get in a car accident. The dashboard comes and hits the knee and forces the tibia posteriorly, tearing the PCL. Again, that's your kind of textbook response. The times I've seen isolated PCL tears is as we're talking about athletics, either at the bottom of a pile with the knee flexed and someone falls onto the femur, or the foot is fixed. And again, generally like a tackle from behind, like those hip drop tackles, can lead to PCL tears as well. Again, not nearly as common as ACL tears, but they can come into clinical practice. One thing I haven't mentioned yet is the amount of swelling in the knee with some of these injuries. So again, you will see some swelling with MCL tears. You will see some swelling with meniscal tears. It's likely minimal. LCL tears, again, likely minimal swelling. ACL tear, there's a ton of swelling. Dr. Horgan will cover this more in DDX, but that's one of the structures where when it's injured, the swelling is almost immediate. You have a very limited amount of time to get in and check the knee. So again, if you're working a sideline event, you should do Lachman's first and see the structural integrity of that ligament. If this walks into your office a little bit later, you may or may not be able to evaluate it depending on how swollen it is. That can be a clue as to one of your differentials, but likely in more of a chronic situation, say chronic, but in the subacute situation, you're going to use more of an anterior drawer. So sometimes the foot and ankle, as we discussed last week, can be a little bit difficult to digest. I think the knee is a little bit easier because, again, you guys have seen it in anatomy. The injuries are a little bit more digestible. And obviously, you've covered it in your Kona courses as well. And those of you that are in DDX or have had DDX have covered this at length. So again, if we look at our MCL, that would be our orthopedic test would be a valgus test. If we look at our LCL, that'd be a varus test. If we look at our meniscus, I like to use McMurray's, but there's a number of meniscus tests. There's a number of any of these tests, really. There's a ton of knee orthopedic exams. And then if we look at our ACL, Lachman's in an acute situation, anterior drawer in more of a subacute or chronic situation. Then you have your PCL, which sometimes you'll see a sag sign, or your posterior drawer. So again, you guys can kind of review those on your own, but just kind of to bring those back up and jog your memory a little bit. And now that we're kind of moving on through some of the more traumatic tibiofemoral injuries, we'll talk about some of the more chronic conditions you'll see as well. Things like Osgood slaughter come to mind. If you're working with a youth athlete, very common to see is that tibial tuberosity pulls away from the bone as the patellar tendon pulls upon it. Again, this can be, in extreme cases, an avulsion fracture. It can be a stress response in repetitive, especially repetitive jumping athletes. But again, normally if you see it in your adult athletes that dealt with it at a younger age, they'll see that big bump on their knee, or even some of those youth athletes that's developing, you see that big giant bump on the tibial tuberosity. Some cases, it almost looks like they have a second patella. So again, just something to kind of note and keep in mind. The next thing I'll kind of mention, just because I see a good amount of them, is a Baker cyst. These will live in the kind of popliteal fossa, the posterior aspect of the knee. They often accompany long-standing meniscus injuries, and any kind of degenerative changes, you'll also see those Baker cyst. And again, that is just normally it depends on the camp you're in. Some people say they form on their own. Some people say they're remnants of a bursa. But you'll get that little cyst that lives back there as you get kind of that rub in the knee. And again, those cases where you have a fusion over a long period of time or some sort of degenerative changes. Before I get too much farther, don't forget any joint can have degenerative changes. That includes the knee. We'll talk about a little bit later with the patella as well. And when I say the knee, I mean the tibiofemoral joint. So you'll get those osteophytes that grow into the knee and can kind of limit the motion of the knee. And obviously, as those degenerative changes and we wear out the cartilage, we wear out the meniscus, we can get that kind of bone-on-bone response. I think it's important to bring this up because sometimes, again, in the knee, it's very easy to think about our ACLs or MCLs. We hear about those all the time. They're kind of commonplace. don't forget, as these degenerative changes happen and maybe some of your older patients need a knee replacement, it's a lot harder to treat those structures in a traditional chiropractic model where you're going to use an HVLA adjustment to mobilize the knee. Again, you kind of switch your gears a little bit. I won't get too far into that, but I will say, please, please, please do a thorough exam. Do not yank on a total knee, because that structure and the biomechanics of that knee is completely different than your normal knee. We obviously need to talk about fractures of the knee as well. Obviously, the femur can become fractured, the tibia can become fractured, the fibula can become fractured, and the patella can become fractured. Each one of these has a little bit of varying degrees. Femur fractures are medical emergencies. If you suspect it, keep them there. If you have a traction split and you know how to use it, but if not, you keep them in that position, you call 911, and you check peripheral pulses and try to keep the patient out of shock. That is, again, a medical emergency that needs to be sent out emergently. If we look at our proximal fibula fractures, again, you can really appreciate it here. The articulation between the femur and the tibia is so great that really you can do a lot of weight bearing at the knee without having to put a lot of stress onto the proximal fibula. So again, don't rule that out, especially if they're having knee pain or they're kind of pointing to the fibular head. Again, generally the proximal fibular fracture happens right under the fibular head as that bone goes from a curved to a smooth surface. It's kind of a weak point for that bone. Again, they're not uncommon. They can come up, and again, they can walk into your office as well, or they can limp into your office, even with a fracture. When we look at the patella, obviously, we talked about Osgood Schlatter, we get that pulling away. We also have tibial plateau fractures that can happen. Recently, in the last few years, I've seen a few non-contact tibial plateau fractures, which is very interesting because you don't think of a fracture as a non-contact injury. I don't know why that's happening. I haven't been able to do any case studies on it, but I've had a few now in the field where it's a non-contact plant and twist, like a anterior cruciate ligament injury. You run out, the history sounds like ACL, but it ends up being a tibial plateau fracture when you refer them out and they get x-rays. So again, it's imperative, again, if you're working sideline or you're the first person to see these injuries, the knee needs to be stabilized or immobilized before transport to either imaging or whoever you're referring to. Again, we talked about tibial plateau fractures. You can have stress responses in the tibia as well from prolonged use. That is not uncommon. And we can also have an osteochondral fracture, which again, you will cover more so in your differential diagnosis class. So again, I won't talk too much about the injuries because you guys get such a good intro into that and a deep dive from your differential diagnosis classes and your CONA classes. On top of the fractures we just covered, obviously, I mentioned it a little bit earlier, generally speaking, it's degenerative changes. Specifically, I mean things like osteoarthritis, again, either in the tibiofemoral or the patellofemoral joints. One injury that's often forgot about in the knee is a posterior lateral corner injury, or a PLC injury. As much as we think about the cruciate ligament being the anterior cruciate ligament as kind of being the most injured, in these posterior lateral corner injuries, the PCL is actually injured more commonly than the ACL, and this also accompanies instability of the knee and the LCL, popliteal tendon, popliteofibular ligament. The lateral meniscus can also be there. So again, you will get a ton of coverage of that in your differential diagnosis class. I just want to emphasize it because it is kind of often overlooked when we talk about instability of the knee in general. Again, these can walk into your office. These can be chronic conditions, not necessarily a traumatic response that you'll see like an ACL, MCL, things like that. Again, as I kind of finish up the major injuries of the tibiofemoral joint, this is not exhaustive by any means. These are just kind of some highlights to kind of keep in the front of your mind. There's a ton of injuries that can happen to the knee. One area I'll dive into a little bit deeper now, after we've gone over kind of the more common injuries you'll see. Don't forget that the knee is a very important joint. It's supposed to be stable. Most of the injuries we've talked about so far lead to instability of the knee. Within those instabilities in the knee that can cause dysfunction, don't forget to check the lumbar spine. Again, knee down, so you have L3 to kind of S1 or S2. Any of those nerves can kind of travel or refer pain to the knee, as well as cause some sort of dysfunction in the knee as well. So don't forget to rule out the spine. Also in the knee, really every extremity joint, I think you should check the joints above and below. With the knee, I'm going to check almost every other joint in the extremity. I want to make sure that that pain that's originating in the knee is actually coming from the knee and not somewhere else. So again, if we look at the knee as being a generally stable joint and the hip is a generally mobile joint, in the general population, the hip becomes very stiff and immobile. So again, then the knee has to take some of those forces. So when we're working our rehabilitative programs and how we can help our patients get back to their normal function, you might have to treat areas above and below the knee in order to treat the knee itself. So again, anytime I look at the knee, I'm always looking at the hip. Obviously, I'm looking at the low back. Don't forget the ankle and the foot as well. That'll kind of transition us into our next segment. So we're going to talk about the proximal tib-fib joint next. This is a plain joint you can see here on the lateral side. And again, if you think about it from an anatomical aspect, it lives in the knee. You can see it's right next to the tibial-femoral joint. We think of that as our kind of main knee joint. But biomechanically, the proximal tib-fib actually has a lot more function to do with the ankle. So if you remember all the way back to CP2, if we're doing our I to S and S to I glides of the fibula, or especially the proximal fibula, we have a contact on the superior and inferior aspects of the fibula. We're actually moving the ankle and foot to appreciate that motion. So again, that just kind of emphasizes how important the proximal tib-fib is to ankle biomechanics. One other aspect I like about this joint that again is often overlooked, let's say you have an ankle injury, the patient comes in, it's a straightforward lateral ankle sprain. You're doing everything you can, but you just can't seem to get the full range of motion back in the ankle, 2, 4, 6, 8 weeks out. Don't be afraid to go check, again, the joint above. So go check the proximal tib-fib and see maybe it's not moving in that segment there and it's causing some sort of dysfunction distally. So again, that's kind of a readily available thing to check, but it's often overlooked. Again, generally speaking, if you're looking at the lateral ankle, if you're looking at an ATFL sprain, the ligament on the distal fibula is stretched, you can leave that joint entirely alone and just attack the proximal structures, or again, focus on kind of your more stability strategy. If we dive a little bit deeper into some of the mechanics of the proximal tib-fib joint, again, go back to your assessments, and that's kind of an easy way to understand the biomechanics. So as the ankle dorsiflexes, the fibula is going to rise superiorly, and it can also move a little bit posteriorly. And then conversely, if I'm going from a dorsiflex to a plantar flex position, the fibula will move inferiorly and anteriorly. So again, those couple motions are very important to keep in mind as we're talking about our proximal tib-fib joint. I mentioned it just a little bit earlier, but I'll reemphasize it again. You can see these proximal fibular fractures fairly commonly. And again, this can happen even in an ankle injury because, again, the stress will move up the bone. That could be the weak point. So again, even if the patient complains of that normal lateral ankle sprain, whatever it may be, they have pain more proximal. Again, it could absolutely be a proximal fibular fracture. You can also get avulsion fractures as well. So this LCL kind of sits on here. You also have your biceps femoris on the posterior aspect of the fibula. And again, your fibula in general has a lot of bony attachments to it. So any of those things can avulse. So again, don't rule those things out as you look at the fibula in general. Again, it's often an overlooked bone because it's so small relative to the tibia. But again, don't forget to rule that out. As we move on to our patellofemoral joint, get my picture here, good. So we get on through as we move on to the patellofemoral joint, kind of a fun fact is the largest sesamoid in the body. So kind of keep that in mind. That's can be a popular test question. But again, as we look at our patellofemoral joint, you can see those surfaces articulate with the femur. And that patellar condyle will sit right in between the medial and lateral femoral condyles, but it doesn't necessarily sit in like a keystone like you think. It actually is kind of outside of that structure and glides along it. So again, something to keep in mind with the patellofemoral joint. As we move into the importance of the patellofemoral joint, I think this lateral view really emphasizes how much of a role the patella plays. So again, all 4 quadriceps tendons are going to attach to the superior aspect of the patella, and then that attachment runs to the inferior pole and eventually to your tibial tuberosity. And again, if we look at the goal of the patella and what it's supposed to do, it creates a longer or a greater lever, especially in extension, and it allows that force from the quadriceps to attach onto the tibia. Without this patella, we'd get a lot of rubbing and friction upon this moment, and so we wouldn't have, one, as great a range of motion probably, and 2, we wouldn't have as much force production. So again, it is a very important structure as we look at it from an anatomical standpoint because of the importance of the knee as far as loading, especially from the quadriceps group and our hamstring group, kind of the big muscles of the lower extremity. It is common for this area of the knee to be injured. So if we look at kind of our general term, it would be something like patellofemoral pain syndrome. It's kind of a catch-all term because it's not necessarily specific. We'll talk about a few. Again, there's more things we can talk about in depth, but we'll just kind of highlight a few of those that, again, you'll commonly see and we want you to be able to readily recognize. The most common one I think that gets thrown around is patellar tendonitis. Again, that's going to happen at the patellar tendon here. It's overused, overstretched, especially eccentrically. So as people are landing from a jumping sport, things like that. And again, we talked about Osgood Schlatter a little bit earlier. That will actually pull on the tibial tuberosity and lead to that kind of giant bump. Or again, you can just get tendonitis in this area, which is very common. It's important when we talk about patellar tendonitis that we have an important differential diagnosis we need to rule it out from. So something like a simple patellar tendonitis should clear up pretty quick. Again, if it's treated correctly, you're looking at a few weeks. It can be a little bit of an insidious onset, more chronic. But again, if it keeps recurring in your patients, I think, again, probably the first thing you want to look at is making sure it's not a referral from the lumbar spine that's causing what they would describe as patellar tendonitis because they looked at Google. Or if you're looking at something like jumper's knee. Jumper's knee can affect both the inferior and superior poles. And the important aspect with jumper's knee versus a simple patellar tendonitis is that it actually has the inflammation, and then it leads to a thickening and tearing. But the really important part is that this tendon can actually become necrotic. So if we're looking at either these tendons here, again, it'll present maybe just like patellar tendonitis. They'll have that point tender pain onto the front of the patellar tendon. Again, conservative care isn't working. They're not improving, and they kind of describe that pain as getting worse. Again, that's something that you need to refer out. They're going to need to take time off to heal that structure and maybe even have surgery. One of my first athletes when I was in private practice was a volleyball player, very prolific volleyball player. She went on to play college volleyball. She was in her senior year when I was able to work with her. She described having patellar tendonitis for the last 5 years. At this point in my education, this is before I was a chiropractor, so I didn't have quite as deep of a dive. But she described this patellar tendon pain. It was debilitating. There was times we had to hold her out of practice, hold her out of games. Finally, I had enough, and I referred her to an orthopedic surgeon who was the first one to enlighten me on the jumper's knee. But she actually had to take a break from volleyball, have it surgically repaired, and then she had a successful college career. Fun fact of that story, she went on to become a physical therapist because of having that injury. And I think a lot of us, got here the same way. You had some sort of injury, you had help, and you kind of moved that way. So again, something to kind of keep in mind that, again, if you're seeing that patellar tendonitis, one, is it patellar tendonitis? Is it some sort of lumbar spine injury? Or is it something like jumper's knee where it has a necrotic, it's offending to the tissue, and it's not ever really going to heal. It's just kind of get worse and worse and worse. So again, something to keep in mind as you look at, kind of your simple cases of patellar tendonitis. Another thing we can throw into that patellofemoral pain syndrome is a chondromalacia patella. Again, fairly common. relatively easy to diagnose. You guys have your Clark's test. Really, any pressure to the patella is going to cause pain if they have a chondromalacia patella. Again, this is some sort of softening of the retropatellar cartilage, and you can look if it's degenerative joint disease or erosion of the retropatellar cartilage. However you think about it, it's best for you. Again, can happen commonly, but again, don't be afraid. Someone with long-standing knee pain, conservative care is not working. Don't be afraid to go look further up the chain. We talked about the prepatellar bursitis earlier. So again, that can be traumatic, direct blow to the knee, very common in football, very common in lacrosse, any sport, basketball, really, where they go knee to knee, or it can be long-standing. Again, patients are gardening, they're out on their knees for several hours at a time. That bursa can become inflamed, but really anytime they're on their knee for an extended period of time, you can also inflame the bursa. Again, relatively simple to heal. It'll become less inflamed over time. If you need to, it can become drained. But again, oftentimes a simple, I won't get into that because it's out of our scope, but again, it can heal on its own pretty easily. Kind of the last major injury I want to talk about is patellar dislocation. The patellar dislocation, if we look at the front of the knee, you can see how much dense tissue, again, is around these structures. We have our quad tendon, patellar tendon, and this is just kind of some retinaculum and attachments onto the patella. So you can see it has a lot of attachments around it because it is such a crucial bone for flexion extension of the knee. If we look at our patellar dislocations, most commonly, we're going to see it displace laterally, or an M to L. Again, this can be non-contact by nature. It can be a blow to the medial side of the knee. So again, those can happen. Make sure if that does happen, that is, again, you need to get them to the hospital as quickly as you can to make sure some of the other structures of the knee aren't compromised. If you happen to see one of these, they are very intense to see. You can tell right away something's wrong. The patient's in extreme pain. Normally, once the patella goes back to where it needs to go, they kind of get a relief of pain. But again, because it's very easy to tear these structures, even if the patella does relocate, it does not mean that they're out of the woods quite yet. So again, you might have to do a deeper dive. The patella, again, we talk about laterally is the most common. It can dislocate in other directions as well. The superior patella dislocation I just saw recently was accompanied by a patellar tendon tear. So again, when I got to the site, right away you can see something's wrong. Again, make sure you calm down the athlete or person that you happen to see that has a dislocated patella. And again, right away you want to call 911. You want to stabilize the knee, and then you want to check some distal pulses. Obviously, you can fracture the patella as well. Not super common, but again, normally it's some sort of blunt force trauma to the front of the knee, and you can fracture the patella as well. So just something to keep in mind moving forward. I think that is everything I want to cover with the knee in general. One last aspect I'll kind of cover before you guys take off is to make sure with the knee, as we're talking about it as being a generally stable joint, you can adjust the knee, and we will talk about knee adjusting at length, but because generally all the injuries we've talked about lead to some sort of instability of the knee, very, very important you choose that tool carefully. Again, someone's had a patellar dislocation before, they're out of the woods, it was a few years ago, be very careful palpating the patella. It's very easy to displace that patella if it's already been injured. If we're looking at someone with ACL reconstructive surgery, again, we have to worry about full flexion of the knee. Anyone with a meniscus surgery, again, we have to worry about that kind of terminal flexion of the knee. Some of the adjustive procedures we'll see put the patient in those positions. So again, very important that you rule out any diagnoses before you go into adjusting the either tibiofemoral, patellofemoral, or iliofemoral, or excuse me, I might have missed one. Iliofemoral, patellofemoral, tibiofemoral. Another thing to make sure with the knee, because a lot of the adjustments we'll do later into the hip as well, and we mentioned it with the ankle, is that anytime you're doing a restriction within the long axis, or you're doing that big pull, you're going to get forces into the ankle, you're going to get forces into the knee, you're going to get forces into the hip. It's hard to differentiate between those structures. So let's say your patient has a total knee replacement. You decide the patient needs a long axis distraction move on the ankle mortise. You don't get to pick where that force goes, so you can absolutely pull on the knee. So again, be very careful again with the knee, because we do see a lot of total knee repairs, and again, generally speaking, the injuries to the knee lead to instability. So be careful assessing the knee before doing adjustments. And again, don't forget to do joints above and below and the lumbar spine. That's all I have for you today. Thank you for coming, and we will see you in class.